Good day. My name is Imelda Williams. This presentation will focus on abnormal radiographic appearances of the pelvic girdle and lower limb, and this is part B of the presentation. Part B includes the femur, the knee, and the lower leg. So before you view part B, please ensure that you have reviewed part A. Fractures of the femoral shaft can be open or closed, spiral, comminuted, supracondylar, or pathological. And here we have an example of a pathological fracture. This is fractures which are quite common in the femur, where there's a fracture through abnormal bone. And sometimes this may be the presenting feature, where patient complains of pain with very minimal history of trauma. And in this case that we have here, the patient has an aneurysmal bone cyst. And because of that area where there's fluid in the loosened area, the bone is weakened and then can fracture quite easily. We can see, especially on the lateral view, that there is a piece of the cortex that has been interrupted. This type of fracture can occur in both the primary and secondary tumors. Fractures of the distal femurs is classified according to the site. So it can be supracondylar, as we see in the top image, and then it can be condylar, where it affects either the medial or the lateral condylar, or it could be intercondylar, as we can see on this image on the bottom right side. I've again included some projections. So there's a projections of the knee. So I want to encourage you to identify the radiographic anatomy, and I will provide feedback on that when I give you the practice bank feedback. The ABC systematic assessment is crucial once again. Ensure that you have the correct views. For example, if there's a suspicion of a patellar fracture, then there's an additional view called the skyline view, which would confirm that the fracture is actually located in the patella. The alignment can be checked by checking the patellar height, but also the alignment of the femoral-tibial condyles to each other. Once again, trace the bones and the contours for steps in the cortex, but also look at the trabecular pattern for any changes in density, such as either a loosened or a sclerotic change. If the fractures are near the joint, or if it involves the joint, ensure that the joint spaces are uniform, but also check for signs of intra-articular fractures. Soft tissue signs are important, as it can indicate that there is a fracture which is not visible, for example with lipohematosis, and I will talk a little bit more about that in the next few slides. In satisfaction of search, you need to check for the possibility of any additional fractures, and for example we have here the Mason-Neff fracture. Now I've given the tangential view or the skyline view of the patella, and this view is to measure the femoropatellar relations. The sulcus angle and the congruence angle can be measured on this view. The sulcus angle is the line that extends from the deepest intercondylar sulcus. So on the image on the right, you can see A indicates the deepest intercondylar sulcus, and then this is drawn medially and laterally to the tops of the femoral condyles. And the normal angle should be approximately 138 degrees. The congruence angle is measured by the sulcus angle being bisected. So BA on that diagram on the right, and this is then drawn to the apex of the patella, and it should be as close to vertical for normal. A second line CA is drawn, and this is drawn from the lowest point on the articular patellar ridge to point A. This angle that is formed is the congruence angle. The average congruence angle is around 6 degrees. If it's greater than 16 degrees, it's associated with patellofemoral disorders such as a lateral patellar dislocation. The image on the left is the radiographic X-ray, and here once again I would encourage you to label those at that diagram. The Ottawa knee rules provides the criteria for selecting which patients should be referred for plain X-rays of the knee. And the Ottawa knee rules indicate patients who are older than 55 or over. And then if there is an isolated tenderness of the patella as well as the head of the fibula, if the patient is unable to flex the knee to 90 degrees, and also if the patient is unable to weight bear, both immediately after the trauma as well as in the casualty department. Inability to weight bear is measured by 4 steps. So if the patient is unable to transfer their weight twice onto each lower limb, regardless of whether they are limping. In the knee, fractures may occur in the patella, the femoral condyles, or the tibial plateau, and the soft tissues are quite often involved with trauma. If the patient is referred for a knee X-ray and the indication is trauma, then the lateral view must be done with a horizontal beam so that the presence of a lipohemothrosis can be identified. And I will discuss this at the next slide. Now, the lipohemothrosis becomes visible as the fat or the lipids from the bone marrow seeps out from an intra-articular fracture, and that then rests on top of the hematoma. So if you see lipohemothrosis, this is a positive sign for an intra-articular fracture. So this is a normal view of these suprapatellar fat pads, and that is indicated as A there. The prefemoral fat pad is indicated as P, and the suprapatellar bursa, which lies between the two, should be less than 5 millimeters. With lipohemothrosis, you can see that there is a lucent triangular density, a lucency just above the patella with a fluid level, and that is the fat or the lipids that's floating on top of the blood, which is denser. When there's effusion in the knee joint, this distends the suprapatellar bursa, and if we look on this lateral view, we can see that the suprapatellar bursa is quite extended, and it obliterates the fat spaces posterior to the quadriceps tendon. This is also indicated in the diagram. Here we have the quadriceps tendon, and then we have the distended suprapatellar bursa. The alignment can also be checked for the patella by measuring the insole-Salvati ratio for patellar height. And this is measured by measuring the patellar ligament length, which is indicated as A on this image, and dividing that by the maximum patellar length, which is indicated as B. And the normal ratio should be between 0.8 to 1.2. A high riding patella, which is called a patella alta, can be caused by a rupture of the patellar tendon, or it could also be caused by a congenital variant. A low riding patella, which is the patella baya, this can be caused again by a congenital variant, but a low riding patella with trauma is due to the rupture of a quadriceps tendon. On the AP view of the knee, the alignment can be measured by drawing a line from the femoral to the tibial condyles, and they should align up with each other. However, if we look on the image on the right, we can see that the medial condyles line up with each other, but not the lateral condyles. And we can see that the tibia is outside of the femoral condyle, which should not be greater than 5 millimeters. If we look very carefully, and it's indicated by an arrow there is a lucency which indicates that there is a tibial plateau fracture. Fractures of the tibial plateau can be classified according to Schatzki's classification. There's 6 types, and from type 1 to type 6 it becomes progressively worse. In type 1, you have a split fracture of the lateral tibial plateau, and then as we move through, we can see, for example, in type 4, where we have a medial tibial plateau fracture, and in type 5, we've got bicondylar fractures, and then in type 6, we have an extension into the fracture line of the diaphysis. Only 25% of fractures caused by car bumpers is actually termed a bumper fracture. This is because of compression on the lateral tibial plateau, and this causes a valgus stress. The lateral femoral condyle is forced onto the lateral tibial condyle. So on this image, we can see that there is a compression fracture of the lateral tibial plateau, and it has a vertical appearance. Can also be associated with the fracture of the neck of the fibula. Tibial plateau fractures are commonly associated with injuries to ligaments and menisci, and the ACL and the medial collateral ligaments are the most commonly affected. So on this diagram, we can see the anterior cruciate ligament tears, the medial collateral ligament tear, as well as the medial menisci tear. With an anterior cruciate ligament, the things you need to look out for on an X-ray is avulsion of the intercondylar tubercle, because that's where the ACL attaches, and then just adjacent to the lateral proximal tibia, you will see there's a small sliver of bone, and that is associated with the ACL. If a horizontal view was included here as well, you would have been able to also see a lipohemathosis. This type is fracture that is also called a second fracture. The medial collateral ligament, if there's incomplete avulsion, a hematoma will be formed between the MCL and the medial femoral condyle, and then over time that starts to ossify. And what we have here on this image is then adjacent to the medial femoral condyle is this ossification, and this is called the Pellegrini-Stader disease. Direct fractures can be caused by a direct blow or with a car accident, where especially the front passenger and the driver, where the knee can hit the dashboard. There's very little protection for the patella, as there's only a small amount of soft tissue, and all of the force is then transferred directly onto the patella. And because of that, patella fractures quite often are considerable comminuted with little displacement of the fracture fragments, and then there's articular cartilage damage as well. Indirect patellar trauma can occur due to jumping, or more frequently to the unexpected rapid flexion of the knee against a fully contracted quadriceps. The anatomy and biomechanics of the knee can create tension and then compressive strain in the patella. Fractures resulting from indirect injury, they tend to be less comminuted and also has less articular damage. On this slide, I have diagrams with patellar fractures. The top two, so on the left there's an undisplaced transverse fracture, and on the right there's a displaced transverse fracture. The image in the middle on the left is a fracture of the lower pole, and then at the bottom we have a comminuted undisplaced fracture. On the right, second from the top, we have a comminuted displaced fracture, and then could also be vertical fractures, and then at the corner you could have an osteochondral fracture. And as I mentioned, if you are unsure whether the fracture is in the patella, a skyline view is really helpful, because on the AP view, we can see there's a lucency, but this could also be a fracture, which intercondylar fracture. Patellar ligamentous tendinous attaches, balances forces and maintains the patella, as can be seen in image A. So the two important tendons and ligaments, the quadriceps tendon and the patellar ligament. If the quadriceps tendon is torn, it displaces the patella downwards as the patellar ligament pulls it down. And then if the patellar ligament is displaced, if there's a tear of the patellar ligament, the patella will be displaced superiorly by the pull of the quadriceps tendon. And here we've got an example on the left of a tear of the quadriceps tendon. You can see that the patella has been pulled downwards, and the image on the right has a tear of the patellar ligament, and you can see this with the pull of the patella superiorly. Chondral and osteochondral fractures. So chondral fractures affects only the cartilage, as seen in image A, whereas osteochondral fractures involves both the cartilage and the subchondral segment of bone, as in this diagram B. These fractures may occur in the femoral or tibial condyles, the tibial plateau, or the patella. In the knee, there's a common normal variance, which is a bipartite, or this could also be a multipartite patella. It can be sometimes difficult to distinguish it from patellar fractures, especially if there's been injury to the patella. It's important to note that the bipartite patella has smooth margins. This can be unilateral or bilateral, and most commonly it would appear in the superior lateral corner of the patella, as we can see on both of those images. Now moving down to the tibia and fibula. Again, I've given the projections and would encourage you to complete the labels on these images. It's essential to include both the knee and the ankle joint when an X-ray has been requested for the tib and fib, as we need to remember that there's a ring-like configuration between the tib and fib, the knee, and the ankle joint. It also helps to demonstrate any degree of rotation, as high energy forces such as car accidents can often result in tib fib fractures, and these could also be often comminuted fractures. Fractures are more common in the middle and the distal third of the shafts. Now in the lower leg, because of the ring-like structure, you could have a fracture which is named the Masonnet fracture. And if you look at this image, you can see that the tibia has got a comminuted fracture in the distal part of the tibia. But if you look very closely around the knee joint, you will see that there is a fracture of the fibular head, as there is an association because of either partial or complete disruption of the syndesmosis. So really important when there's significant ankle fractures, then to ensure that the whole of the leg is included with the head of the fibula. Stress fractures can also occur due to repetitive stress applied to bone. Please be aware that plain X-rays are not as sensitive, and it can take up to 2 weeks for the fracture to appear. And when it appears, we see the periosteal reaction. So basically, it's the callus formation that becomes visible, and stress fractures appears as a sclerotic band. If it's important to identify whether there is a stress fracture, then I would suggest a nuclear medicine examination, as bone scintigraphy is much more sensitive as it picks up the activity at the fracture site. Now, pylon fractures can occur due to a fall from a height, car accident, or skiing. It results in comminuted distal tibia fracture, which extends into the tibio-talar joint. It's also associated with fractures of the distal fibula, the talus, and subluxation of the ankle joint. There is a Mueller classification which is based on the degree of displacement as well as the joint incongruity, and this you can see on the diagrams on the right-hand side. This is the end of part B. So thank you for that, and after you've gone through part B, I would recommend that you then go to part C. Thank you.